Good morning, everyone. First of all, it's a pleasure and an honor to be here. It's been such a wonderful weekend to actually be meeting with all the families. I'm extremely touched by the amazing dedication you all have to, this condition. And hopefully together we can further our understanding of it and hopefully get to where we all want to be, which is better quality care for our children, better therapies, better treatments, which is certainly the goal for me personally as a geneticist. So I'm delighted to be here. I'm from Seattle. These are some pictures of the beautiful Pacific Northwest. Please come visit us sometime. Everyone in the room probably knows what the features are of Smith-Kingsmore syndrome and the genetics of it. So I definitely don't want to, reiterate what everybody knows very well, and many of you have been living with this syndrome for quite some time. And of course, the tribute goes to some of the earlier reports of Smith-Kingsmore back, way back, where it was reported, in very few children at the time. But since then, of course, we've come a long way. And we know that there are a lot of features, as was highlighted very nicely just now. So there are a lot of features of this disorder. Our clinic, my clinic in Seattle, is focused really on children who have abnormalities or changes in their head size. And this is really how we came about into working on mTOR and SKS, is that I see children in my clinic basically who their head growth might not be tracking where it should be, whether it's too big or too small. And we all know, that many people out in the community might have a slightly larger or a slightly smaller head size, around what we call, this is +2 standard deviations above the mean, and this is -2. And a lot of people are, again, out there have different variation in head size that could be sometimes familial, and it's totally fine. But what we have noticed is that sometimes when children have way larger head sizes or way smaller, that's when the possibility of a genetic condition kind of comes into play. And we start having a conversation early on, especially if it's like at birth, noticed at birth. We'll have a conversation early on about possibility of a genetic disorder, maybe an overgrowth disorder, and we start thinking about offering genetic testing as early as possible, if we can. And this is really how we kind of came about. Again, we're very focused on the neurological kind of features, and I'll show you a few other aspects of that as well. So for a lot of our families that we've seen in Seattle, certainly, again, it's typically prompted by noticing maybe a slightly larger head size at birth, maybe some of the low tone that's noticed early on. We typically do a brain MRI very early on at our center. So we'll do a baseline brain MRI scan just to see what does the structure of the brain look like. And granted, not many centers do this, and certainly there are families whose child may have not had a baseline brain MRI scan. And I'm always happy to answer questions about that. Is it needed for my child? But this is another area where we have been really focused on, you may take this with a grain of salt. So this is what we call ascertainment bias, meaning that we see the families who have had early brain imaging and may have had something on their brain imaging. That means that there might be a lot of other families whose brain MRI scans, their children's brain MRI scans are completely normal, and there's nothing to worry about there, right? But this is kind of the area we've been really focused on, is to understand what does the brain look like, and how does it function, right? So in terms of the brain MRI scans for our children, most of the time, children have what's called megalencephaly or macrocephaly. A lot of the time, and this is a brain image I'm showing over here, where the brain is structurally normal. So when we look at it, it's structurally normal. There isn't a focus on it that could cause, for example, seizures, let's say. However, there are a fewer number of children who might have some changes on their brain MRI scans that could be informative. And we see that sometimes, where sometimes the surface of the brain, which I'm showing over here, might have what we call cortical dysplasia, which means that the surface of the brain, which essentially looks like a walnut, we all have these curves and folds in our brain, it just, there might be some irregularities, some abnormalities that could, cause some problems, like most commonly seizures. There are other children who might have abnormalities that are asymmetric, meaning that one side of the brain might be a little bit larger. SKS, as we all know, is an overgrowth disorder, and it varies. So that means it could be bilateral overgrowth, or it could be that one side of the brain is actually bigger than the other side. Sometimes we actually see that even what 1/4 of the brain, this is shown over here, so it's like half of the brain, sometimes it's just one little area, which is the circle here that I'm showing. One little area is a little bit bigger, a little bit dysplastic. What does that mean for those children? It usually means that their seizures could be more focal. These kids in this image, this is an image of what's called hemimegalencephaly. Some families may have gotten that diagnosis, and it could be a scary thing, because if you look in the hemimegalencephaly literature or online, you see a whole bunch of things that are different than SKS, So we have to understand fully, what does that mean for the child? But a lot of the time, the seizures could be focal, for example. Some of the families may get referred to a neurosurgeon to talk about some surgical options, stuff like that. But again, if we take a step back from some of these more focal forms, in my experience, at least at our center, most of the families with SKS typically will have, either a normal MRI scan or just bilateral, symmetric bilateral enlargement of the head without a whole lot, going on. And it's important to understand why seizures happen, if they do, in both groups, whether there's nothing to show on the scan and if there is a change. We need to understand why are seizures happening in both situations. So the other kind of specific thing I wanted to call out, just in case there are families also living with this, is that sometimes we see a very distinctive pattern on the brain MRI scan, what's called PMG. And I'm sorry, this is written in a very small font up here. PMG is called polymicrogyria, which means that all the folds we have in the brain, we might have too many of them, and they're too small. And sometimes we see a specific pattern where it can affect the mouth muscles, the oral motor region. This is by far the most common pattern of PMG we see on MRI scans. It's not common in SKS, but it's seen in a small percentage of children. But it can cause very specific things. It can, because it involves the motor region, so these are the mouth muscles, it can cause early onset feeding difficulties. So when families say, yeah, my child I'm not able to wean them into solids, for example, it can cause a lot of drooling and then expressive speech delays. And so what families usually will tell me is, my child, I feel like their receptive language is really good, but their expressive language is really delayed. They're not able to verbalize. And if we see that and they haven't had a brain MRI scan, we'll usually say, well, let's just get a scan and see what it looks like. But this is a very specific entity. It happens infrequently, but still occurs in SKS. And it has very specific implications for medical management, because then the focus of speech therapy should be on expressive communication. We can think about assistive communication devices. For excessive drooling, there could be some interventions. For feeding difficulties, we would need to be on top of them and really try to be very proactive about feeding issues. So it can have some practical implications. The neurological consequences of a child with a large head, from our experience, are very different than if there's a child with a small head size, which, so SKS pretty much falls in the large head size, of course, category. But what we've noticed across, years of literature and research as well, is that a lot of the time, kids with a large head size can have low tone. This is seen across many syndromes, by the way. The low tone, large head size combination kind of goes together sometimes. Seizures can usually, can happen, of course. And there could be, as I mentioned, some brain MRI abnormalities, which is shown over here. So sometimes just by virtue of the child having a large head size, it has certain implications for some of the challenges they may have. It is usually less than, a child with a small head size. So if we take two children, one with a very large head size and one with an equally, on the opposite side, a small head size, the children with microcephaly or a small head size typically have a lot more neurological consequences. So it's very important for us to track head growth early on. We really keep a close eye on it in the first few years. We ask the pediatricians to really track it almost, every 6 months. And in the first year, actually, it's usually like almost every 3 months, we would want to see where is the head growth, going. So I just wanted to kind of mention that. The other area that I know Dr. Kruger will also hopefully mention as well, and which is his area of expertise as well, is epilepsy. Epilepsy is something we see quite often with SKS, and we see quite often in general. I'm not going to regale this room of information about how common epilepsy is, Many of you have been living with it in your own families, but it's certainly a very important problem. As a geneticist, what I do want to call out, and I think many of you may have appreciated this, that epilepsy often does not exist in a silo for a child. When epilepsy occurs in a child, certainly early on in life, it typically comes with a lot of other problems. And what the relationship is between these other problems is complicated sometimes. So many children with epilepsy have sleep disturbances. Many children with epilepsy have feeding and GI issues, mood, behavior, attention. So there are a lot of things that go along with epilepsy, and the neurology societies and neurologists typically do a wonderful job at trying to assess the magnitude of these problems. But again, it often doesn't come as an isolated package for the child. It comes with other things. And what's really important when it comes as part of a genetic syndrome is that, until now, unfortunately, oftentimes the diagnosis is not uniform. So depending on where the child is, families may go through very different journeys. But early diagnosis is very important. And the treatments are not uniform across centers in the country, but we know that there are a few lines of treatment that are really, really critical. So we have anti-seizure medications, which are, tried and true in many centers. The ketogenic diet, which, some families some children may be placed on. Surgical approaches, which I know for some families with SKS, they have been discussed. And then, of course, mTOR inhibitors, which we all know could be relevant. So the genetics of it, just because, just to cover everything, but really I think all the families probably have had this maybe somewhat painful conversation about this, is that most often it happens as a result of what we call a de novo mutation. Right, so it's what's called a brand new or a sporadic genetic change that happens early on in pregnancy, typically to healthy parents. And they may have had many healthy children, and then they have a pregnancy affected with Smith-Kingsmore. So it happens early on, where the spontaneous mutation can happen, by the way, either in the egg or the sperm, we don't know. And then, it can basically, at fertilization, it leads to an affected child. Or pregnancy. So I just wanted to comment as a geneticist, just because, I think while most of the families have come here, it's after a diagnosis has been made, right? So many of you have gone through this journey. New families may still go through this journey, families that may get diagnosed tomorrow, right? So in case you're wondering, for some families, they may have gone what's called a diagnostic odyssey, sadly, which is a phrase we really like to dispense of in genetics now. But some families may have gone through a long time of testing after testing, single gene or panel after panel, and then afterwards, they get the diagnosis. These days, we have what's called comprehensive genetic testing. What I mean are the last two categories, exomes and genomes. So exomes and genomes are big genetic tests that cover a lot of our DNA. These are usually the fastest ways now to get a diagnosis for a child with any, developmental difference. And these methods caused a rapid upstick in finding genes. So this is a curve showing how slow it was to find disorders and solve them, and now it's much faster. So this is really, I think the goal is, to offer early genetic testing and comprehensive genetic testing early on in life. But if your family has gone through a much longer journey, it's unfortunately the case that oftentimes, depending on where you're seen and what kind of genetic testing is available at the local center you're being seen at, it might be a much longer kind of journey. But we hope to change that. I'm going to skip this just in the essence of time, and I'll share with you just one last story. I'll wrap up this one story of a child we had actually seen in Seattle, this is Alden, who has gone on to become a young man who's extremely wonderful, and his family was extremely amazing to work with. He had epilepsy surgery early on because of his severe epilepsy, and thankfully his surgery was curative. He's gone on to do wonderful things, and he's doing really well. And we found an mTOR mutation on him that was mosaic. So for any families living with mosaic mTOR mutations, it's a whole different bag of beans, right? This mutation was very, at 9% of cells in one part of the brain that was triggering the seizures, but there was a gradient. So other cells, we tested many samples that were surgically resected. In other areas, it was at 3%, and then 1%, and then even in some parts that were still abnormal, it was 0%. So it means that the cells were still not behaving the way we would like them to, but they didn't have the mutation, which means that sometimes these cells talk to each other. It's not just about having the DNA change. There's a more complicated, sometimes biochemical relationship between the cells. So this is Alden and his family's contribution to research resulted in a breakthrough in our understanding of the genetics of mosaic mTOR. And so it's extremely rewarding and important to do these kinds of studies. And I think I'm gonna stop over here to respect the time. Yeah.
Thank you, Dr. Mirzaa.
Yes, of course. I'll leave my slides up in case there are questions. Yes.
If anybody has any questions, we will ask you to talk into the mic. So we're recording this for folks who can't make it here. So questions for Dr. Mirzaa.
Thank you. I don't know if this question applies only to our daughter Freya, but she actually has a normal head size. Now, obviously, she has SKS. So, do you have any insight into that?
Yeah, I've heard of a few families like this as well. I typically, bear with me, I'm a bit of an OCD and a helicopter parent and physician, so I'll tend to double check any head size measurement when they walk to my clinic. I'll double check it, as well, just in case, because, with little babies, there could always be variations. But yeah, I've heard of a few families, and this is where I think you guys would be extremely, it would be extremely helpful to hear about that, because it really helps us understand, because mTOR fundamentally, it's a growth gene, and it lives in the mTOR pathway, which is a growth pathway. And we all, as a physician, we always have what's called a bias in that, again, we're going to see the kids who have differences, right? So seeing a child who has a normal head size is very helpful to understand, well, what does the full spectrum look like? And it's important to, of course, correlate it with the genetic change, what we call genotype-phenotype correlation. Could there be some variants that are, that cause less head overgrowth? I think that's a really key question. Absolutely. Yeah.
Thank you.
Yeah. Thank you.
Questions for Dr. Mirzaa?
Thank you. On the genetic testing, so what are the things that we can do or help to make it more accessible for families to get that available?
Yeah, so this is a very good question. We have this conversation often now with our families, is what can I do to make sure, we don't want other families to have to deal with the diagnostic saga we have gone through, right? So I'll say a couple of things. So at the level of the genetics community, the American College of Medical Genetics, so on the professional level in genetics, this has been going on now for years. The ACMG has sent clear guidelines in the medical literature and in medical communities that early diagnosis through exomes and now genomes are considered standard care for children especially children with neurodevelopmental differences. And it should be considered what's called first tier, diagnosis, first tier or first line diagnostic, option for families, which is basically telling the community of pediatricians and neurologists, that think about exomes and genomes early and don't do, if you can, and if you have the resources at the hospital, don't bother sometimes with panels and single gene testing here and there because it's not efficient. It takes a lot of time, a lot of insurance money, and it's extremely frustrating and emotional journey for families. So exomes and genomes have become first line, investigations for children born with neurodevelopmental disabilities or neurodevelopmental differences in the US. Now, granted, families who live in centers that might have very low resources, they might not have a genetics even team, or a neurologist who actually can order testing. It's a harder thing. So I'm always sensitive to where the family's coming from, or from outside of the US, right? There are countries that might not have, Europe, they do a lot of exomes and genomes, but there are other parts in the world that are much less resourced. But what I tell families, so in terms of like family engagement, is get to know where they are, and introduce to them the idea maybe you should talk to your doctor about early genetic testing, and if you can throw in the words exomes and genomes, if they're, which are the big tests, of course, that would be ideal. Have a conversation with your doctor about exome sequencing or genome sequencing. Genomes are just offered, by the way, like they just started being offered last year and this year. Exomes have been around now for more than 10 years. So there might be exomes might still be the best option for a while. But really, I would tell families, have a conversation early about genetics if you are, worried. As family groups go, we've had a few family groups actually approach us and saying, we want to advocate for early genetic testing, so in their material, their educational, material that's online. Even we've had a few families, actually, there's a family group we were working with who they're actually going to, locally in their community, they want to meet with their primary care, some of the primary care centers, and just give like a 5-minute kind of presentation about early exomes and how that has helped discover their genetic condition. So they're very, proactive. There's lots of, things to do within reason, So yeah, these are just some thoughts from my experience, I think, to throw around.
Thank you so much.